So I think at that point we are ready to get started. So our speaker tonight is Professor Scarlett McNally. Professor McNally went to medical school in London and then Cambridge and qualified as a doctor in 1989. She's been a consultant orthopaedic surgeon in Eastbourne since 2002, honorary clinical professor at Brighton and Sussex Medical School since May 2022, and BMJ columnist, giving opinions every fortnight since September 2022. So without further ado, I will hand you over to Professor Scarlett McNally.
Hello, and thank you all for coming. I'm going to share my screen because I've got lots of slides. So it's actually far too many slides, but I'm just going to whiz through. There's quite a few pictures, there's quite a few with numbers. I'm just very aware that everyone's got a slightly different view, and so I'm just giving you lots of things that I'm thinking, and it's not like a teaching thing that you have to learn everything or take it all in. Some things you won't be interested in. So this is me, and I always say at the beginning of any talk kind of who you get money from, because some people are sponsored by drug companies or something. And I do lots of voluntary things. All the things below the line are things I do for fun. I've been working with Swim England on how to do make sessions more available for people with disabilities and long-term health conditions and that sort of thing, but that's for fun, for free. And the Centre for Perioperative Care pays my hospital for half a session of my time, and that's where I work in Eastbourne, as you can see, just along the coast from Brighton, and it's completely lovely. We've got lots of medical student placements there, and foundation jobs as foundation doctors if you want to come back and work with us in the future. And also it's a 500-bed hospital with lots of other clinical roles if people decide to embark on one of the other NHS careers. So I'm talking about me, and I'm very aware that there aren't that many women orthopaedic surgeons. So I'm going to talk about that with statistics and dispelling some myths. So this is a picture from a kind of guidebook about how to fix an operation, how to fix a fracture up in the near the shoulder. So you can see it's kind of quite clear about what you do, and you can go online when you're in a hospital and see what kit they use. So if they use the company called Stryker, you go to the Stryker website and you put in surgical technique, and you can just download the surgical technique, or if they use Smith & Nephew or something. And that's quite good if you're a student or learning to know what ought to be happening. So then you can practice what ought to be happening and see, what drill you use first and how it all works. And it's not that difficult. In the old days we did it from books, but now it's all available online. And here are some kind of facts about orthopaedics, because it's about bones and joints. It's one of the biggest specialties. And basically all bones heal in 6 weeks. In children, it's a bit quicker. A fracture is the same as a break. We use the term interchangeably. And what we do is reduce the fracture, hold the fracture, and then get the patient moving. A joint is where two bones meet. So the knee joint is between the femur and the tibia, and we do quite a bit of replacing joints when they're worn out. So you replace the end of the femur and the top of the tibia, for example. We haven't got that many operations really. We fix things if they're broken. We replace things like joints. We fuse things, which means if there's a joint that's really, particularly if it's really unstable, or something where you wouldn't want to replace it because it would be too wobbly, like the ankle or the wrist or some of the finger joints, we put screws through them. And we also take out stuff that shouldn't be there. And when you're assessing a patient, you look at them, you feel what the problem is, and you take x-rays and things, and then you move it to see whether it's stable, whether that's the actual joint causing the problem. You have to kind of examine the patient. And then when you're clerking, when you're getting the patient ready for an operation, excuse me, you've got various bits you're thinking about, like, why should you do something? What's their actual problem? Because a lot of the time they've got a problem, but it doesn't need an operation, or you might try a different way. Then their fitness for an anaesthetic, and then how they're going to manage afterwards. Excuse me. Sorry, just getting over a cold. So just going back in time, this is a long time ago. That's what, 30 years ago. I just qualified as a doctor. And this was the first meeting of women in surgical training. And I put the circle around me and my friend Farah, who's still my friend. She's a professor in Swansea, and she's a cardiothoracic surgeon. And these are other people who, you know, all different stages, but there weren't that many women at the time. And now we've got 6,000 members, and people can join. And it's not just supporting the women getting into surgical training, it's supporting the women in surgery that aren't necessarily looked, if there's a senior job coming up or a role, they aren't necessarily invited because people forget to invite them, is often the problem. So we help with them. We tell them to go and find out about a job and see what it's really going to be like and push themselves forward if that's what they want. Again, this is about 1992. You can see this is me on a surgical course, and some of these people are still my friends today. And again, so it's about 10% at that time. And this is the kind of hurdles. And actually, I know I'm 30 years out of date, but it's still pretty much the same. So you have, in the old days, you'd have a year as a house officer and then about 3 years as a senior house officer or SHO. And then a big hurdle into your registrar training, which was your specialist subject, as it were, like orthopaedic surgery or children's surgery or ear, nose and throat or something. That's when you, being a registrar is when you're then learning just your specialty. And then it's a new hurdle to apply for a consultant job. And there are exams at various points, but those are the big hurdles. And actually it's still about the same. It's now called foundation training, which is 2 years. SHO, it's called core, but we're back to calling it SHO now. And then as a registrar, you're the one often making decisions in the hospital, but in your specialty. And I just urge you to think about that age 29 thing, because that's really when people are making that career defining moment. And once you're a registrar, you kind of, it's easier to see the endpoint. You can get on and be a consultant. There are other roles available as an SAS doctor, that's specialty doctor or associate specialist or specialist doctor. So these are people who are not in training programs, and you can apply for those after you've been a doctor for 4 years. And some people do that and spend their whole lives being an SAS doctor and loving it and staying in the same place. So you don't have to go through this training thing. You don't have to end up being a consultant. And actually half the people who graduate, half the doctors become GPs. So this is, I'm really just talking about the hospital side of things, and particularly surgery. And this is really what happens at age 29. And I think this is why there was such a big problem with women in surgery in the past, because that's just the median age for first pregnancy in the UK, and median age for first marriage in the UK, I should say, and people are having babies at that time, and it's when men and women are at their most different, in my opinion. But actually, there are ways. That's accepted now that surgery is quite a long training, and that parents need to be supported. And there is a new initiative from the Royal College of Surgeons of England about supporting parents in surgery of all genders. And surgery's really changed. There's more team working, there's less night working, more specialisation. When I became a consultant, I had to argue why I wasn't going to do back surgery. I said, you know, it's not just I don't like it, but you have to be quite good at it to do back surgery, because they're all the, you know, spinal cord and everything. And there's no point me just doing it, you know, once a year or something. It needs to be in places that they do quite a lot of them. So I kind of had to argue that at the time. And now, and I gave up doing knee replacements, for example, when we appointed another knee surgeon. People then specialise in their areas, such as arm or hip or back or knee. And so you do your registrar training as very general, and then you specialise at the end with a fellowship. And I went to Australia for a year to practice doing arm surgery, basically. And it's also, we've now got our results public so that people can see our kind of complication rates. And that really focuses people on just doing what they do well, and making sure everything's as good as it can possibly be for every single patient. And the hours of work have reduced. They were over 100 hours a week, and now there's a maximum of 48 hours a week in every single specialty, and it's possible to work less than full time. And this report came out when I was a registrar in surgery in about 1999. And it's from the National Confidential Inquiry into Patient Outcome and Death. And it's called Who Operates When. And basically this said, and obviously it's based on data from 1996, a couple of years before they've been collecting it. It basically, at the time, 41% of emergency operations started out of hours. And what it said is that the patients have a worse result if they're operated on out of hours. And there are some big reports that just change how something is done. And this, in my view, was really important, because after that, hospitals basically stopped doing anything at night that wasn't life-threatening or limb-threatening. And that meant, and they got put in an extra operating list during the day, so that if someone came in at night, say with a broken ankle or something, you take x-rays, you'd put it in a temporary plaster, you'd stick the leg up, give the patient painkillers, put in a drip, and then they go to sleep, and you'd have everything ready for 8 or 9 o'clock in the morning. You'd have a meeting at 8 in the morning, and then you start operating at 9 on all the trauma cases. You'd almost expect them to be trauma cases, and you'd go in at 8 o'clock in the morning, even if you haven't been on call the night before, and you might be on duty to do the trauma list. And this is what happens now. So you don't need to be up all night heroically saving lives and operating on your own and all that stuff. You can go in the morning and meet the patient and have the discussion, and you've got a new team coming in that's really helpful and wants to be there, and you talk about the kit, and you do a really good job, and you can go home for tea. It's that kind of, it's a totally, I can't explain it well enough to people who weren't there last century, how different it is. And the big problem I see is that lots of people about my age, I'm 56, I know I don't look that old, but I am 56. Lots of people my age are now running medical schools or giving advice or being really senior somewhere. And they don't realise that the last time they did surgery or saw it as a medical student or in their first couple of years, it was rushing around all night and being busy. And actually now it's much more team-based, and it's lovely, and you don't have to be there all the time, and there are fewer complications, so you don't have to be there to reoperate on people all the time, because surgery is actually better. A few statistics: 6% of consultant orthopaedic surgeons are women, and that isn't really changing fast enough. And I think it's because women are not applying so much, and also that support for parenting isn't quite there yet, but we've got a few changes. This was some data I collected and published, so data from 2005, and it's the percentage of, for all the specialties, percentage of people applying on the x-axis, the percentage of success rate of whether you get in. So it's all specialties like palliative care and geriatrics and emergency medicine and everything. But the ones in the red circle are surgical ones, and they're very competitive, were very competitive. They're a bit less competitive now. And the percentage of women applicants applying at the time was quite low, the highest in children's surgery, pediatric surgery. But it was quite low, and I was trying to suggest they were correlated. But things have changed a great deal, and now 30% of the applicants for surgery are women. So I was kind of trying to prove that women want to do it in the end. And this is a bit fuzzy slide because this was before the internet, this paper, not quite before the internet, you know what I mean. But it showed other specialties have changed. Obstetrics and gynecology changed, and anaesthetic changed, being very male dominated. And things can change, people can change, cultures can change very, very quickly over just a few years. And I've done quite a lot of stuff about trying to improve the culture within surgery and within other specialties. And this was a paper that they do cohort studies, this group, Goldacre, and they published something 10 years ago showing that women from a certain era were far less likely to have children, and women surgeons, than men surgeons, because you almost at that time really did have to choose between your career and having a family. But now you don't. That's the message I'm trying to get across. And actually now I did another paper showing the women who did apply were statistically significantly more likely to be appointed. So there isn't discrimination, but we need more support. Sorry to kind of labour the point. And I've done quite a lot of stuff around trying to make sure everyone remembers they're a role model. And just to point out, I'm not the person you need to think about if you want to think about being a surgeon. This is Miranda, and she's now a consultant in Eastbourne, and she's great. And that's a picture of her when she was my registrar, when, you know, in the old days we have white coats and jackets and real live x-rays rather than on the computer. And she was part-time when she was training as a registrar, and she's got 2 children. She's full-time as a consultant. She's fantastic. And so you don't need to be running around doing stuff with the Royal College of Surgeons and doing examining and writing papers and writing columns from the BMJ and all the stuff that I actually really like doing. You don't have to do that stuff. You just have to turn up, do a good day's work, and that's great. That's fantastic. And furthermore, if you do the training less than full-time or part-time, you can be a full-time consultant because it's much, much easier. And surgery is really amazing because it's not heroic. It's really lovely. And there are, 25 operations in each particular body part, for example, and you get good at doing them and you know what's going to come next, and it just works. You've got the team with you and it's repetitive and it's lovely because you're dealing with a different person each time, different patient. Do they want it? Is it the right thing? How are they going to manage? It's just lovely. And you've got the whole team and they kind of question what you're doing and ask, oh, do you want this with that one or whatever, sorting out the kit and all that. And we've got really good protocols so people are ready before they come in, so they don't have to spend too long in hospital, so they don't get hospital problems of being in hospital. And it isn't so much at night. As I said, I'm not on the on-call rota anymore, but I used to be able to, if someone phoned me at night, I'd walk into my study, turn on my the x-rays and be able to phone the back going, actually, that'll be fine. You put in the plaster, that can wait till the morning. Great, night, and go back to bed. So it wasn't, whereas up till 1999, we were, if there was an operation to be done, you would get on and do it. And things have changed again with seat belts and airbags, because you'd frequently have 2 cars smashing into each other and have to deal with 4 patients from the same collision. And now you don't. And that is absolutely huge. As I said, all jobs are maximum 48 hours a week, every single specialty. That's the law at the moment. This government has threatened to change that because it was European law. And you can apply for less than full-time training for any specialty. Most people choose to work 80% of time, so they kind of get the equivalent of 1 day off a week with their family or to sort out the sporting commitments or whatever they're doing. And again, once you've got a permanent job like being a consultant or SES doctor, you can again work part-time. I work part-time now for various reasons, which I'll go into if there's time. So this is a timetable. This isn't my timetable because I said I work part-time. But this is a normal timetable. This is for a normal consultant. So about half your time is in clinic. There's me, a long time ago, in clinic, and there's me operating. About half in clinic and half operating. And then you have some extra time like teaching or administration, organizing things, that kind of thing, that's included. And most consultants would have a non-hospital day per week to do their private practice or to do whatever they want to do, really. And then most people are on call maybe once a week or the equivalent of once a week. You might do a week on call at a time and then have a few weeks not doing on call, but that's kind of factored in. So that is a typical full-time consultant role as a surgeon. Not really enough operating in it, in my view, but that's the way you go. And lots of people do more than full time. They do 11 or 12 sessions. But anyway, I'm just saying it's easier than the training phase. And this is what I used to do on my Thursdays. I was a council member of the Royal College of Surgeons of England for 10 years, and that was fun. You can see I fit right in there. And we did manage to get a lot of change. And this is from one of my last council meetings. And there's my friend, there's me in the bottom right-hand corner. There's my friend Victoria Pena with her new baby. So it was changing. It's becoming more female and more ethnically diverse. And these are the people who applied the year that to be my replacement. You can see it's becoming more diverse. When I applied, it was only one woman and not many people of colour. But things are changing, but you've got to work out how to change things. You don't have to, but I'm saying I've had to try and get some change. So, encouraging people to apply who wouldn't necessarily apply, telling them it's only write 150 words and you get voted in, and work out what the real hurdles are. Because the people who applied then did get selected, and the person in the bottom right was appointed. She's my replacement, Nuha, and she's amazing. She's really buzzy. And it's quite difficult if you kind of don't fit in to a group. What do you do? And there are kind of two ways of doing it. You either be your authentic self, and that's fine. You do, Nuha's wearing a headscarf. She's being, very, as I say, she's being great. And some people kind of fit in almost like being an honorary old boy, as it were. It doesn't matter. You don't have to do something the way someone else tells you to do it. You have to basically have the knowledge, have the skills, have the exams, know what the hurdles are, and get on and do it your way. So it's really about focusing on what the real hurdles are, not what someone tells you. Is it an application? Is it an interview? Are you elected, kind of thing? So for you, how do you get into medical school? What are the steps? Or for applying for surgery, what do you need? So often you ask the people who are doing it, work out. You might want to do some research, get a poster, work on a poster, that kind of thing, get some, go on some courses, get some certificates, all that kind of thing. What do you need for the next stage? Rather than just relying on people telling you because they might be out of date, get information from lots of people. So yeah, it's collecting evidence. We produced, when I was at the Royal College of Surgeons, we produced a booklet called Careers in Surgery. So that's rcseng.ac.uk/career. And I did another one /study, which is all the study materials that I helped write. And it's basically using your time and working out what's actually effective for you, because a lot of people spend a lot of time hanging around the wards that actually isn't building up their CV. This is during surgery. They need, it's good to be really focused on what being in theatre, being in clinic, working out why decisions are being made, and that sort of thing. And then you work out what specialties you want. Do you want big operations, little operations? Have you got a long attention span? Do you want to be in all day reconstructing someone's neck after a cancer operation? Or do you want to do lots of tonsil operations or that kind of thing? Do you want to be in a big centre with lots of specialists, or do you want to be in a nice district general hospital? It's that kind of thing. You've just got to work out kind of what you want, but you've kind of got to have your antenna tuned that when you're in a hospital, just think, oh, what's their job like? That's quite interesting. I might want to do that, rather than getting stuck in an image of what it's like, because it's not necessarily like the image. And also in 20 years' time for you, or 30 years' time, it won't be the same. Yeah. A little bit about parenting. I've got 4 kids, and we need men and women to you need to put the time in for childcare. We need people to work less than full time, just because you do need to spend a bit of time with the kids. And it's about valuing people for when they're there, because there is, it's not, you can't actually have it all. You can't actually do everything and be perfect at everything, because something's going to fall apart. And actually, you don't need to. You can be good enough. And particularly at work, you've got a team around to help you. And at home, you sometimes need to make more time for your kids, for your partner, than you realise, because things just do take time. This is one of my beautiful children, and it should be idyllic, shouldn't it? Beautiful child. I'm not going to tell you she fell off and broke her arm. No, she didn't. She's now at medical school, which is lovely. She's amazing. But if I had my time again, I wouldn't have 4 children. That's far too many. It has a really bad effect on the planet. And anyway. So they're my beautiful kids, but it's not all that idyllic stuff. Sometimes it's just catching up. I've put all the other stuff, the head lice and the party bags and trampoline accidents and the school run and having to collect them from school trips and all sorts of things that you just weren't when you were having your idyllic, how many lovely children are we going to have chat. Actually, one kid's enough, or a family with no kids, or lots of nieces and nephews. All of it is fine, whatever people want to do with their lives. But I think you've got to really think about it. Just don't have something you don't talk about. And also to say, pregnancy is a short time in a career. There's a picture of me being very, very pregnant. That my kid's now at uni, that youngest one. You can work with X-rays. The machines are designed not to completely zap your baby because they're designed to be used by people that didn't know they were pregnant, kind of thing. And we've got guidance. There's guidance all sorts of places. And breastfeeding, we know breast is best for babies. It's difficult if you're working, but you can do night and morning, and the baby will take a bottle during the day. This is how to express breast milk, because otherwise your breasts get really uncomfortable. So you just, it takes about 20 minutes and you put it in the freezer, and then daddy or the childminder or whoever can give it to the baby later. So, or you can throw it away if it's just to keep your breastfeeding comfortable. And you're allowed to take up to 12 months off work. You can share it with your partner, so one takes some time off and the other one doesn't. And I know, some people won't have kids, but actually, if you do, you just fit it in and you go back to work. It is a short time in a career. And you can, as I say, work flexibly or train flexibly. And 23% of consultants this is in the Royal College of Physicians rather than surgeons, but I think it's similar. We just don't have data, work part-time. And be nice to everyone if you've got kids, because you'll need the childcare and the backup for the childcare. So you might have their grannies or aunts or whatever that will help. This is a school run by bike with daddy. And actually, I could go on and on about this, but under 10, they're actually lovely, the kids, and you've got to create memories with them and take inset days, teacher training days off. And then as teenagers, they need stability, and you actually need to be there in order to be ignored sometimes. But you need to have all these other adults and grannies and stuff to support them. So it's quite an endeavour. And then suddenly you've got your kids leave and you've got lots more time and energy. And then you're part of the sandwich generation, looking after your own parents that might have dementia. But there are problems with respecting everybody. And the Queen Bee syndrome is some women not supporting other women. And there are problems with how culture is and what's seen as normal that we are trying to change. And I put this up because sometimes people think you have to be perfect as a surgeon, and actually, a lot of the time there's something going on in the back of someone's mind that's really messing up their head, and they've managed to get to work and they're doing a good day's work. And we're all human, and sometimes some of that stuff's happening in the back of your head. You're worried about someone in your family or something, but there's a minimum standard that you will achieve because you've got all that training and all that support from the team around you. And it's not one or the other. You get on with it and the team will help you out when you're having a low time. So I'm just kind of sowing that seed. You don't need to be perfect. And also, with the gender thing, this is Margaret Thatcher, who's the first woman prime minister in the UK. And some women have always made it. But the problem is, if we don't support people who are different, with disabilities, with different ethnicities, different backgrounds and all that, into the middle kind of management roles and the extra things you have to do, we haven't got them to choose from for the top roles. That's what the pyramid thing is supposed to show. And there is a gender pay gap in medicine. I could go on about this, and I'm president-elect of the Medical Women's Federation, and we're helping look into this. And there's something called imposter syndrome, where people think they kind of don't deserve to be there. And there's a sort of pre-imposter syndrome where you don't apply because you think you won't get selected. And actually, lots of people have it. And the kind of people who have it are the kind of people who are really thoughtful about thinking, really challenging themselves. Should I be operating? Really working with the patients. And they're kind of people we need. So actually imposter syndrome isn't a bad thing, but people need to think people need to know they're good enough. If they've got the exams, they've got the skills, that they're good enough. And I read this about avoiding unconscious. You can't actually avoid unconscious bias. That's when you kind of make a decision about somebody almost before they've opened their mouth. But I was trying to train surgeons not to do that, so that they were more welcoming to people. And this is from the Association of Anaesthetists, about if somebody's being stressed, trying to get the team to help. Like, I notice you're stressed. Is there anything we can do to help? To try and change that image of people being allowed to be shouty and rude. I mean, obviously, if you've just dropped the one thing on the floor that you really needed, you are allowed to say, oh, bother, and be cross. But you shouldn't take it out on one person. Do you know? So it's kind of trying to change how people do things a little bit, so that they're politer. And then if they're really annoying, have someone take them aside and go, actually, that really wasn't okay. Are you okay? Are you okay? Have you got something going on that's messy? You know, just to try and get the team working a bit better. So it's about knowing what you need to do. It's like a party invitation, knowing what, you know, what the start time is, what's expected, what the rules are, and you're allowed to ask that information, but also people are allowed to give that information. And you can't penalize, you know, for the people with those in training, doctors in training in their departments. They can't be cross with them for not knowing something that they didn't tell them, if you see what I mean. Yeah, I'll move on. So that, because of that, we wrote an undergraduate curriculum in surgery. It's not, medical schools don't really use it, but it was what the Royal College of Surgeons would put out as the kind of minimum that every doctor should know that about surgery, because you want the GP to know, oh, this might need an operation, this particular thing. So this is particular thing I can send to the hospital, or oh, this thing, you know, after an operation, it should be like this. It's not like this. Maybe they need a follow up, or, oh no, it's fine. It should be like this. This is what they're always like. So that sort of thing. So we wrote this, and I'm very proud of that. And it's also to be able to talk to patients positively about what an operation might involve. Anyway, it's got various bits. And I've also encouraged people, our surgeons, to get the medical students scrubbed, so that so they feel part of the operation and they can learn about it. Not everybody's a kinesthetic learner, wants to have their hands in things, but so they feel part of the team and understand physically that you're unblocking a tube, or you're screwing the bone together or something. And it's not that difficult. If you hold what instrument you're given and you say if you've got to move, if you feel a bit faint or your finger's gone numb or something, you just say, can I move? And you move. It's not difficult. And this is, the curriculum's in that kind of, like every curriculum, knowledge, skills and attitudes. And there's not that, you know, it's a finite number of things. And once you really think, oh, actually, that's doable. You know, it's not kind of, oh, magic. It's doable. And I've kind of led on a suite of these things that about trying to make it clear what's required. A little bit of how to get changed. I've got that picture of the clean up after your dog at the bottom, because when you're trying to get changed, it's not all about the individual changing. It's also about changing what society thinks of as normal. And now it would be really weird if you let your dog poo on the street. But when I was growing up, it wasn't. And I think what changed is, you see that picture, the human in that picture's got a pooper scooper, so they're scraping with a thing and putting it. It's like, what do you do with a little pooper scooper, the plasticky thing that you used to be able to buy? Do you put it in your handbag? Do you throw it away? Do you clean it in the, you know, where you do your washing up? I think that was the thing that stopped people from engaging with this must clear up dog poo. And when people started using a plastic bag with a kind of, you collect it and you tie a knot and then you walk around and you put it in a bin, I think it became easier. So you need the practicalities. If you want to get people to change, you've got to introduce the practicalities to them. They've got to have that knowledge of why it's important, the skills and how to do it, and the ability to do it. And then it's got to change so that the culture accepts it and their family thinks it's normal and the professionals help. And then you've got to change institutions and how it's funded and that kind of thing. And I've put the picture about cycling because this is really important. This would be a key way of getting the population healthier if we had more people being active. But it's not just about telling people to cycle more. You've actually got to put the infrastructure, you've got to put the cycle lanes in so that it's safer for people, and you've got to get culture and society to accept that it's actually healthier to cycle. You're 10 times more likely to have a problem because of lack of exercise than to have a problem with your bike, even allowing for pollution and collisions. So it's the kind of three-pronged attack, as it were, on how to get change. And that's a picture of my children, 3 of my kids, with my husband being supportive. There we go. And this is a picture from the Women in Surgery conference in 2020, which is lovely. I found all the people with babies, and we did a nice photo shoot in the beginning. So it is, because your life goes on at the same time as your work, and you need to fit it in. And my husband laughs at me for doing work-life balance talks, but actually you're in it for the long haul. My husband was a nurse in Brighton. We met when I was an SHO in Brighton. There we go. And now a few slides about health and exercise. And I was lead author for this booklet called Exercise, the Miracle Cure, and the Role of the Doctor in Promoting It. And this basically collated all the evidence that if people do exercise at a dose of 150 minutes a week, so it's about 21 minutes a day, it's primary prevention. It reduces someone's risk of ever getting type 2 diabetes by 40%, or breast cancer by 25%, or dementia by 30%. And at the time, it just seemed crazy. People didn't know that. As I say, my mother's got dementia. I don't want to get dementia. And I go out on my bike every day, partly for that. But we need to get more people to realise that. I now have an electric bike because I got some health problems. But yeah, we need more people to kind of realise that health isn't just about being treated for disease. And this is, so it's not just me saying that, this is the chief medical officers of the 4 nations of the United Kingdom. And they said for all adults every week, you should do 150 minutes of moderate exercise, and also strength twice a week and balance twice a week. And children should do an hour a day. And the infographic I've put up there is the one they have for disabled adults, because even people with disabilities ought to be getting 150 minutes a week of exercise. So we need some way of doing it, and so maybe it's using a hand cycle, maybe it's swimming, maybe it's walking up and down stairs, it's whatever, but actually it really, really does make a difference. And the biggest benefit are for people who do least at the moment. So this is a kind of a slide about the relative risk of up to 1 of getting something, getting a condition, and then with how many minutes of exercise, or they're called MET minutes. So it's, and I've put the red triangle at that 150 minutes a week we've talked about of moderate exercise. So it reduces your risk, say, of heart disease very, very quickly. So it's people who do nothing, who sit on the sofa all day, actually just going for a walk every day will have a massive improvement. Do you see? Because the slope of the graph is so great. And after an hour, beyond an hour a day of exercise, you aren't having that much benefit. And beyond that, you're really starting to add up some injuries. So, and this is from a paper that was in the BMJ. I didn't write this, I just borrowed their slide. So it works slightly differently for different conditions, but we need to get the population more active, because we simply cannot afford the number of people who are not getting enough, who could prevent some of their problems by doing that much exercise. And there's a group I'm working with, the Centre for Perioperative Care. We've got cpoc.org.uk/patients. It's got all this stuff for patients who are getting ready for an operation, called Fitter, Better, Sooner, trying to get them to do a little bit of exercise and to eat well, because then that halves the risk of complications after an operation, reduce them by half. And if you tell people to do that, actually they do it, because they're so keen. If they've got something to focus on, they'll do it. Whereas at other times, it's kind of people that, I'll go to the gym later or something, and then they get around to it, or it's raining, I won't cycle, it's raining. So, but people, I think we aren't getting this message across as doctors. And this was from the Exercise Miracle Cure report about why, people, 95% of people should just get on and do a bit of exercise, about 5 times a week, maybe about 30 minutes, or different, different combination. Moderately intense, they get a bit out of breath, just get on and do it. And only 5% are in danger of having a problem if they've got really bad heart pain when they're exercising, and they need to be referred to someone specialized in that. And otherwise, just start simple, do a bit more. And I've been working with movingmedicine.ac.uk, and they're amazing. So do have a look at, they've got a lovely video on movingmedicine.ac.uk about, how exercise is good for you, and also how to have the conversation as a health professional, so it doesn't sound like you're saying someone's fat and lazy. It's so you're going, so it might be good for your health. What might you do? Had you ever thought about doing a bit more exercise? And then someone says, I might walk the kids to school. You go, oh, brilliant idea. So when might you start? You kind of have a conversation with how fast the patient wants to go. And I think it's been lovely for me working with them. This is from Macmillan, the cancer charity, because people who are given a cancer diagnosis and have a few weeks just to get ready for their surgery, they have the best results, because people will almost do anything. If you tell them it might reduce your chance of a problem, they will do anything. And they have amazing results. They reduce complications by 50%. And this is what I work with, this is Tuesday afternoons and some other times, about perioperative care being the whole journey from a decision to operate, from the primary care person, the GP referring in, to the person being back at home afterwards. And it's about sharing information, shared decision making, so the patient knows what risks is fixed. You can't change the fact, some fact about you, like your mouth doesn't open very far for the anesthetic might be difficult or something, but you can change that you've got high blood pressure. You might be able to improve that with daily walks, for example. So we're doing that stuff and talking about team working. And this is about multiple conditions. So on the bottom, the x-axis is the age, and the number of conditions goes up on the y-axis of what the percentage of patients with no conditions, or 1 or 2 or 3. And at age 60 or 65, it's actually at age 65, 50% of the UK population have 2 or more long-term conditions, and that makes things much more complicated. So they might have complications after an operation. You need doctors to try and manage all their stuff, whereas some of patients who've just got one thing wrong with them, you can have the specialist nurse can manage, say, the asthma or something, but as soon as they've got asthma and heart failure and kidney failure, it's quite difficult to manage that. So you need it's much more complex, it takes much longer. And if you imagine, I was talking to someone from Northern Ireland today, and they said the percentage of their population that's over the age of 65 has gone up by 25% in 10 years. And that's massive. And we simply can't afford the number of people who are this old. And the problem is, people think getting old is inevitable, but getting unfit is not inevitable. And all the conditions that go with it couldn't necessarily all be prevented, but maybe if we could reduce them by a third, with people being active and eating the right food and not smoking, we wouldn't have so much worries with social care, with people trying to look after other people. These are the numbers again from the Exercise Miracle Cure report about the reduction in risk. And also, not does it reduce risk, but if you've got type 2 diabetes, one of the best things you can do for your health is get some exercise. And similarly, all the other things. And the lifetime risk of all these things, dementia, your lifetime risk of ever getting it is 15%. These are all quite high, quite common conditions. I wrote something on what we should call junior doctors, and the answer is doctors. We should call them all doctors. We shouldn't distinguish, because a junior doctor just sounds a bit lowly, and they've got amazing qualifications, and we need to support them because it's a fantastic job. But we do need some tiers. People need to know if they're seeing the foundation doctor or the SHO or the registrar. And the registrar, as I say, they run the hospital. They're good in their own specialty, or indeed they might see the consultant or the specialist. And I try and work with teams to value everybody and stop and slow down. If someone hasn't worked in that area before, really support them. Particularly these are some of the nurses I work with and the practitioners, and they're just lovely. And they want to do a brilliant job for the patients, and you can all work together. And if there's a problem, you kind of analyze what the problem is, because it might not be what you think it is. And I've done stuff with, for example, the receptionist being able to hand out patient information leaflets so that everybody knows what you're trying to do. They're not kind of guessing. And this is my last slide. Kind of focus on the real hurdles. And you don't have to be perfect. You have to kind of be clear, get the knowledge and that kind of thing. rcseng.ac.uk/career is the one if you're wanting to go into surgery. ScarlettMcNally.co.uk has got lots of things I've written. And if you're on Twitter, I'm at Scarlett McNally, but you get an awful lot about cycle lanes in Eastbourne and how we need to have more. So I think that's it. And I'm going to stop sharing. Thank you.
Excellent. Thank you, Scarlett. That's great. So if anybody has any questions, please do pop them into the Q&A. We've got about 10 minutes or so just to answer as many as possible. I've seen that there are a few that have come in over the course of the talk as well. So that's great. Thank you very much for your talk there. So I'll ask you a couple of these. This is quite a good one, and it sort of links into the stuff around the time that it takes to train as a surgeon. So somebody's put, how do you cope with feeling somewhat behind your friends/colleagues in other specialties when at around 30 you're still having to take exams and things while other people are settling down, etc.?
Thank you. It never actually really bothered me, because this sounds dreadful, but I didn't have a plan B. I wanted to be a surgeon, and I was going to be a surgeon. And so I just kept on going. And also, as soon as I was a registrar, I knew that effectively I couldn't be kicked off the training program unless I did something really bad. And I knew I'd pass the exams eventually. And so you just kind of settle in and get on with it. And we did have a house. I know nowadays it's a bit more difficult. I'm really sorry, people. But we got married in 1995, and we bought a house in Brighton, in Kent Town. And so I actually had 3 of my kids in the Royal Sussex County Hospital while I was a registrar, and took some time off for each. So for me, it was a job. I know maybe I'm a bit weird, because I actually quite like doing exams, but it didn't feel like a burden. It was just what I had to do. And, I've got friends who are solicitors and stuff, and they have to get up really early to get all the paperwork done, or barristers that have to read the brief the night before and then defend somebody or something. So it didn't feel like such a big deal. But critically, there was absolutely no way I'd have been a GP. I don't mean this badly, but I don't have the attention span. I'd give everybody you've really got to go for a walk every day, because it'll make you better. And then if they come back in a month's time, oh, doctor, these tablets aren't working. Like, did you go for a walk every day? Well, I couldn't have done that. I really couldn't have done that. Yeah. So I'm not sure if that answered the question.
No, I think it did. Yeah, no, it was really good insight. We've had some really good questions come up here. So I've got a good one here. If you could choose, or if you could choose another specialty, what would it be?
Oh, that's a really good one. I really like plastic surgery. I did plastic surgery for a year, and that was at East Grinstead. And that is amazing, because every operation is different, and it's not the plastic surgery you see on telly. It's reconstructing people who've got cancers or trauma or something else, and you basically are moving some tissue around to fill a gap. And that I really thought about doing that for a long while, and then but orthopedics it was kind of simpler. It kind of makes sense. You can see what the problem is. You can show people the X-ray. And also at the time, the people were nicer in orthopedics. I think a bit like you could, partly because you can see on the X-ray what operation people have done. And, it wasn't all about showing off how great you were, just talking about it. It was like, oh, no, you've got the screws there a bit long, what are you doing with that kind of? It's a bit more kind of, it felt like an honest kind of specialty. And with patients, you have a real discussion about, do they really want you to operate on their painful thumb joint or something, or could they, get a splint or get a dishwasher so they're not having to grip, or, it just, yeah, plastic surgery probably.
Excellent. So we've got a couple of really interesting questions that sort of link quite closely together. So I'll ask you both of them because they sort of work together. Has anything surprised you about the way that medical school and surgery has changed over time? And then the other question that we got was, what was the main difference you found with the process of you entering medicine compared to your daughter?
Okay, thank you. Those are very good questions. The thing that everyone should know if they're applying to medical school is that there are different types of medical courses. And interestingly, my daughter has applied for one of the most old-fashioned ones. So there's not much difference because so she's doing the split where you do 2 years essentially in the classroom in the lab and the anatomy dissecting, and you don't see a patient at all, and you have incredibly difficult exams. She showed me her exam papers, and blimey, I'm so pleased I didn't have to do quite such difficult ones at the time. So yeah, and mine was fairly old-fashioned with anatomy and physiology and biochemistry in the first year, and pathology and mechanism of disease and all that stuff in the second, all that. And then you go see patients after that for 3 years, often with a year in between. But there are other courses where you see patients from day one, problem-based learning courses. So you need to go, if you think you learn in a particular style, you probably ought to go and find out which ones do which. And there are books you can get. I always recommend, there are books like I can't remember what it's called. So which medical school do I go to type books, or so you want to be a doctor type book or something. There's something that will list out which is which. And I think it might even be on the Medical Schools Council website of which sort of which. So actually some just haven't changed at all, and lots have changed a lot. And what was the other question? Sorry.
It was just about, I think you sort of answered both of them there, really. It was about sort of how surgery has changed over time as well, I suppose. Changed. Yeah.
Well, interestingly, the biggest change, as I kind of mentioned, was that we don't heroically have to do something on our own in the middle of the night and at weekends. It's become much more team-based during the day. Some of the implants are just amazing. When I started orthopaedics, you get a kind of blunt sore or something and you just expected to get on with it. And now you get it's beautiful kit. It's so lovely. It's a bit like if you like cooking, someone does the washing up afterwards. It's just, exactly what you have to do and it's in the right place. But when I was coming to the end of my registrar training, so around the year 2000 kind of thing, I went to Australia for a year. And I did that because I thought that surgery was going to be all about going through telescopes, and I should learn how to put telescopes into the shoulder, how to do operations, with a telescope in the wrist, in the shoulder, and all that stuff. And actually, we do that for knees and things, and a bit for shoulders, but we don't do it nearly as much as I thought it was going to take off. Because basically, you can have a good look, but you can't change that much. And actually, if the big surgery needs doing, you can do it open. That's for orthopedics. Obviously for general surgery, quite a lot is done, with a camera around the belly button and that sort of thing. But so it hasn't actually changed that much. And I think all the stuff with robots, great in some specialties for some particular things, but it's quite a lot of faff and quite a lot of plastic, sleeves over everything. It just, sometimes the old-fashioned stuff actually does work. So not as much change as I was expecting, really.
Excellent. We've got another great question here. What has been the best and hardest part of your job? Ooh. They don't have to be the same thing. They could be two separate things.
The best part is just doing an operation and it works and the patient is better. It's just so... And particularly if you know what you have to do and then you do it and then it's done, and you know, it just works. I mean, there's some operations that are just gorgeous. Everything all makes sense, and it's so lovely. The worst part, I guess, is if something goes wrong, if you have a complication and you just feel awful. You just feel like it's your fault, and that you'll never get over it, and it's just you're such a bad person and it's really bad, and you know, all that, and you go over and over it in your head, and it does always get better eventually, but it's that's why it's good to have a support network that takes you away from all that. And sometimes for everybody, patients and doctors, just human beings, we're not very good at putting our life into perspective or our career in perspective. And sometimes you just get absolutely fixated on one awful thing, and then, but eventually you'll get over it, you know, because that's how the human brain works. You process stuff, you go through all that guilt or grieving or something, and yeah, and you get there, but you know you've actually done your best, you know even if something goes wrong, you know you've done your best deep down, and you do get over it. Yeah.
Excellent. So I think we've got time for one more question, and I think this is a good one to finish on. What do you think is the biggest misconception about your role?
I think people think I just operate all day from the beginning of the day to the end of the day, and that it's really big and heavy and strong, and you know you have to be hauling legs about and all that business. And actually you don't. It's everything. Everything's kind of precision. So if you're doing a nailing of a femur or something, if someone's broken their thigh bone, you attach their foot to a foot plate and you wind out to the right length, and then so you don't have to do all the heaving about. And I think in the old days you probably did have to do a lot more heaving about, but now things are much more precision, so you don't need to be big and strong, and you don't need to be doing, you know, from 7 o'clock in the morning to, you know, midnight, banging things in and all that stuff. It's actually, you know, most operations are, I don't know, an hour, a bit more, a bit less, and then you stop and you have a break and you write the notes and you have a coffee, and then while the anaesthetist is getting the next person anaesthetized, and then you do the next. So, you know, and then you have, let's say, half your time's in clinic, and then a bit of the time is teaching, and all that stuff. So it's not nearly as, I don't say this out loud because I'm getting paid for being a surgeon, but it's not nearly as hard work as the public think it is. But you know, but I'm taking all the, you know, the credit. But it's it's just so lovely to turn up and you know what you're doing it with a team, and you end up and it just works. It's I can't think of doing anything else, you know.
Excellent. Well, thank you very much again for your talk, and for answering those questions as well. Please enjoy the rest of your evening. Thank you very much, folks.